How's it going, guys? Medium difficulty question for neuro. Steps 1 and 2. 30-year-old woman. She's got a 1-week history of worsening urinary incontinence characterized meaning to run to the bathroom 8 to 12 times daily. Similar episode 3 years ago. She was treated successfully with oxybutinin. This is urgent incontinence. Okay, so 8 to 12 times daily, and oxybutinin is the buzzy pass level drug that we use for urgent incontinence. It's a muscarinic receptor antagonist. We can also use mirobegarin, a beta-3 agonist. I've never seen that assessed on NBME material. NBME is not the same as Qbank, okay? So we have a couple episodes of urgent incontinence in this patient's history. Mechanism is hyperactive detrusor muscle. Physical exam shows Babinski sign on the left. That's an upper motor neuron finding. Clonus of the right hand. That's also an upper motor neuron finding. What's most likely to be part of this patient's acute presentation? This is multiple sclerosis. Okay, this is a pass level presentation, in fact. So it's medium difficulty because there's stuff we'll discuss, but you've got a woman 20s to 30s who's got urgent incontinence and she has upper motor neuron findings. Very, very buzzy and easy for multiple sclerosis. Okay, now some students say, can it be overflow incontinence? Never fucking seen on NBME material. All right, it's going to be urgent incontinence. It's all over the place. And let's just hop to the answers. Choice, what's most likely to be seen? Choice A, downward mobility, vesco-urethral junction, wrong fucking answer. It's very buzzy for stress incontinence. It's grand parity, many childbirths, classically, 50% of vignettes probably. Can be loss of urination, of course, with intra-abdominal pressure increase, coughing, sneezing, laughing. You're not going to treat this with medication. That's high yield. You treat it with pelvic floor exercises, aka Kegel exercises. 14 out of 15 questions. 1 out of 15, if those don't work, you can do mid-urethral sling. Wrong fucking answer. Choice B, fasciculations, right thenar eminence, wrong fucking answer. It's a lower motor neuron finding. So the way you can assess that this is wrong is when you look at this vignette and you overwhelmingly say, that's gotta be multiple sclerosis and lower motor neuron findings are not part of the presentation. Okay, so when you think of ALS, amyotrophic lateral sclerosis on USMLE, there's 2 requirements for that vignette. Number 1, the combo of UMN and LMN findings. So UMN, Babinski sign, clonus, hyperreflexia, hypertonia, LMN findings, fasciculations, hyporeflexia, hypotonia, atrophy. That's the first finding, the combo of UMN, LMN. The second is no sensory abnormalities. I've never seen urgent incontinence as part of it for USMLE for ALS. Choice B, wrong fucking answer. Choice C, inability to abduct the right eye when looking to the right, wrong fucking answer. So medial longitudinal fasciculus syndrome, internuclear ophthalmoplegia, is essentially pathognomonic for multiple sclerosis in USMLE. If we had that, when the patient looks to the right, they would have an inability to adduct the left eye. So the MLF is going to link the cranial nerve 6 of one eye to the cranial nerve 3 of the contralateral eye. And the side that cannot adduct is the side that's fucked up, okay? So you need to know MLF syndrome is MS on USMLE, and also optic neuritis is pathognomonic for MS on USMLE. Optic neuritis, inflammation of cranial nerve 2. You can get a myriad of findings, central scotoma, which is a blind spot, diminished visual acuity, diminished color vision. You can get a Marcus gun pupil, which is relative afferent pupillary defect. Wrong fucking answer. Choice D, normal convergence of the eye is correct answer. So in MLF syndrome, even though you cannot adduct with one of the eyes, when you look laterally with the contralateral eye, you can converge normally, which tells us our cranial nerve 3 is intact. It's just a finding you have to know, okay? It's not overly nitpicky. It's just sort of a neuro high yield point, okay? So you can say in MLF syndrome, that's pathognomonic for multiple sclerosis, as is optic neuritis. In MLF syndrome, the patients can converge normally, which tells us that cranial nerve 3s are actually intact. It's just the MLF that's fucked up, okay? Let's just hop to the final answer choice. Post-fed volume 400 mils, wrong fucking answer. That would be overflow incontinence in USMLE. And we know it's not overflow incontinence because oxybutinin successfully treats, and that would make overflow incontinence worse. Okay, so we give bethanechol for overflow incontinence. That's a muscarinic receptor agonist. But as I said, and that can be diabetes, classically hypotonic bladder, neurogenic bladder. As I've said, I've never seen overflow incontinence in USMLE. They will classically tell you post-fed volume 300 mils, 400 mils. Normally it's under 50 to 75 mils. Wrong fucking answer. You know the deal. When you make more content, like myself, from my channel. Appreciate your time. That's it.